We're moving on to a keynote address by Dr. Sankar V H on the topic, Time to Switch Over to Non-Invasive Prenatal Testing. Dr. Shankar is the additional professor and consultant geneticist, Department of Pediatrics, SAT Hospital, Government Medical College. Over to you, sir.
Thank you for introduction. Respected chairpersons, Jayakrishan sir and other seniors, my teachers. Shamla madam is here. Valsama madam I have seen somewhere. Okay, so many of my teachers are there. So it's always a pleasure to talk in the obstetrics and gynecology crowd. And sir is always give me a chance to talk to that crowd in advances. So today the topic is non-invasive prenatal screening or non-invasive prenatal testing, where we are and whether we are ready to switch over to that. So the overview of the presentation will be a concepts of prenatal screening and different options to start with, so that then only you can compare with the conventional methods with the NIPS and reliability of the various prenatal screening methods. Then what is NIPS, what is the techniques, and what is the importance of fetal fraction. Some of the only very few basics about the techniques, because I think it is very difficult to explain as well as understand in a very small period. And what is the test characteristics of the NIPS, and what are the steps in implementation of NIPS in your clinical practice, what are the limitations, and how to interpret the report, and if time permits, because recommendation, all of you know, it's all available in the net. So just for a completion's sake, I have put major recommendations by your own ACOG as well as ACMG, our organizations. Just combine some of the recommendations if time permits. But I think that is not mandatory because that is available in the net. So what is a concept of prenatal screening? Because even now, some of the youngsters or clinicians may confuse between prenatal diagnosis and prenatal screening. So first you should have a difference between a screening and diagnosis. So screening actually in a population among apparently healthy pregnant women, identification of those women who are sufficiently at risk of a specific fetal disorder to justify subsequent risky or expensive prenatal diagnostic test or procedure. So this NIPS or NIPT is basically a screening procedure. It is not a definitive diagnostic procedure, and you should not take an irreversible decision solely based on the NIPT, and it is equal to other ultrasound and biochemical screening process only. So it is a prenatal screening, it is not a prenatal diagnostic methods. So if you take the major milestones in prenatal screening, the prenatal screening was started later only, but prenatal diagnosis started in 1960s when amniocentesis were done for karyotype to diagnose the Down syndrome. Then chorionic villus sampling in 1980s. But later people understood that we may not be able to do this invasive testing for every pregnancy to identify. So we should have a screening method to screen some of the high-risk pregnancies where we will do the invasive diagnostic test. And 1990s prenatal screening by ultrasound markers and biomarkers, because there are two groups of people, ultrasoundologists who are identifying day by day newer and newer markers they are identifying. At the time, newer and newer biomarkers are also coming. So this was the period of 1990s, and 2008 onwards, the non-invasive prenatal testing came, where we can directly do the genetic methods in the maternal blood to identify the fetal DNA, which I will come a little bit later. So there are so many conventional methods. Don't worry about the slides because it is a busy slides where NT sonogram, NT plus serum analyte, second trimester, maternal serum AFP, triple, quadruple, integrated, combined, sequential, various things you would have been heard. The detection rate varies from 64 and reasonably good for the 95%. It is actually from the ACMG Genetic Medicine Guideline 2023, where they have beautifully described everything. It is 95% is the upper limit. That is in the best comprehensive screening model. That means you are doing the ultrasound, immediately in the next room you are doing the blood sample you are taking, and is correct crown drum length you are measuring and adding. But usually practically in our setup, most of the private setup, it may not be possible. One day you will do ultrasound, after 1 week you will do the blood, then it is not correct. If you are doing as a combined properly method, up to 95% detection rate is there. Just remember that because we will come to NIPS later. These are various methods, nasal bone inverse. So here's the detection rate at a false positive rate of around 5%. So false positive rate 5% has been fixed perfectly because we have to compare the various methods. In a false positive rate of 5%, it is somewhere around 95 to 95% is the detection rate in the best possible combination. So more important thing is positive predictive value. I don't know how many of clinicians are using this positive predictive value because detection rate and positive predictive value is totally different. Positive predictive value is more important for a clinician where you are getting a report as a prenatal screening positive. What is the chance of having a Down syndrome baby? That means if you are having a combined test positive, that is a first trimester screen positive, there is only 3.6% of chance of having a positive Down syndrome baby. Still it is 95%, it's a non-Down syndrome baby. You understood that? So it's only 5% chance. Detection rate is different thing. Detection rate is the test and what is the characteristic of the test. But for a clinician, more important thing is PPV and NPV, positive predictive value and negative predictive value. Positive predictive value means just only remember that you are getting a result and that result is screen positive. What is the chance of having that baby is Down syndrome? Or in another way, as a geneticist, I have to do, if 5% is the positive predictive value, I have to do 100 amniocentesis to detect for the 5 patients. So 95 amniocentesis, it will be negative. That I think probably most of you are feeling that. You are getting a screen positive, you will send to a fetal medicine people, they will do amniocentesis, test will become negative. Once in a while only come it becomes positive because positive predictive value is not very high. But still we can definitely identify Down syndrome. That is why we are using that screening test. Now coming to NIPS. NIPS, what are the major milestones? Actually in 1997, cell-free fetal DNA in the maternal serum and plasma were identified by Lowe and al. And 2008 is the next major milestone where possible to screen for T21 by sequencing of cell-free fetal DNA in maternal plasma with a very low false positive rate. By Fan and al. And Chu and al. They described the first paper on 2008. From 2011 onwards, introduced this method for commercial use as a screening test in various parts of the country, including in India. And previously, India, there is no labs were doing it. The sample was going to Singapore and various places, and we are getting the results. But after 2014-15, so many Indian labs are also doing the NIPS in India. So, actually, cfDNA can be a fetal as well as maternal. It is actually from apoptosis of the placental trophoblastic cells, in situ trophoblastic majority, and highly fragmented with the variability in size based on tissue origin and processing. Maternal fragments are slightly longer than the fetal fragments, and average size of the maternal fragments is 166 base pairs, whereas fetal is 142. So that is actually how we are differentiating whether it is a fetal fragment or a maternal fragments. Usually these maternal fragments will be little bit high, and average length of the maternal fragments is 166 base pair, whereas 142 for the fetal, and size and genomic regions available for analysis will help to do. So these are some of the technical details which I think if you are not able to understand very well, it's okay, it's not important. But this concept is important. Fetal fraction is very, very important. Fetal fraction is the amount of the cell-free fetal DNA in the total cell-free DNA. That means if it is fetal fraction is 5%, that is 95% is maternal DNA. The higher the fetal fraction in the maternal blood, the result is more reliable. That is, I will show one example after this, how this calculated. At 4% of fetal fraction rate, detection rate is only 62%, while above 9% it reaches 100%. Another important point is cell-free fetal DNA can be detected from 5 to 7 weeks, but it is rapidly increases after 10 weeks by around 1% per week beyond 20 weeks. So generally means when it is a little bit advanced gestational age, cell-free fetal DNA will be more. In an early gestational age, cell-free fetal DNA will be less. But as a screening method, we want it early. So there should be a tailor-based method. You have to decide which will be better. If you do at 16 weeks, knock-all rate will be less. If you do at 9 weeks, knock-all rate will be more. But generally, it has been all bodies are recommended that NIPT should not be done before 10 weeks. It should be first earliest possibility is 10 or 11 weeks, but there are failure rate will be little bit more if you do 11 weeks or 16 weeks. That I will come in the implementation part. Why this fetal fraction has been changing? Fetal fraction is directly related to crown drum lung. That means if it is increase in size, increase in gestational age, fetal fraction will be more. It is related to placental apoptosis, which is indirectly related to Papa A and free beta HCG. So when free beta HCG is elevated, naturally fetal fraction also will be increased. And some of the race, like higher in East African races, higher in smokers, less in the Asian population, decreases with increased maternal age, body mass index, teen pregnancies, South Asian women, IVF pregnancies, women with a high PI of uterine arteries, twin pregnancies, and in some of the fetal aneuploidies like trisomy 18. So I am got interested in the second part because these are the situation where we want to know that it is definitely there or not. Most of the high risk will come to these areas. So these areas, there is a chance of increased failure rate. That is the most important thing which we will discuss about the failure rate or counseling. Then another important factor is collection of blood sample, because he required minimum 10 ml of blood sample for this NIPT test. Then only we will get enough fetal fraction. So appropriate sample collection is very, very important. 2 ml, 3 ml is routinely we will get. We will always say, why 10 ml is required for this? 10 ml is required because only you will get enough fetal fraction. And it should be an EDTA tube, purple top, preferably 10 ml. And centrifuge within 6 hours of plasma and store in -80 for transport or immediately, then only fetal DNA will be stable. But this is a conventional method. But none of you has bothered about it because this was the method we were using in 2011-12 when we were sending out. But now I think every company is having their own special cfDNA collection tube, which is a cell-free fetal DNA blood collection tube. Stabilizes the sample for up to 5 days at room temperature, should not be frozen. So I think Genome or Newberg or Cell, everybody is doing it. They are having their own collection tube with needle and package, and they are having some gel pack system is there. There you don't have to bother about the freezing and plasma separation, etc. because cell-free fetal DNA will be stable there. But for students, conventionally it should be plasma. If you are taking plasma, immediately it should be and should be hemolyzed and short in -80. And what are the techniques used? You know, samples are fetal DNA plus maternal DNA, I told you. You just take 10% fetal fraction, 90% will be maternal DNA. You can test for chromosomal abnormalities, copy number variants, microdeletions, or single nucleotide polymorphism. Anything can be tested. But there are so many limitations are there. I will come to that. Methods can be a massively parallel sequencing, which is called a genome sequencing, entire genome sequencing, or it can be a chromosome selective sequencing or multiplex PCR, data analysis by counting or genotyping. I think these are the terminology which may not be commonly aware, so I am just going about. Whole genome sequencing is the massive parallel sequencing, otherwise called shotgun sequencing, where maternal and fetal cfDNA fragments are sequenced and the chromosomes of origin are identified through alignment with the human genome. So that means you are having a pool of free fetal DNA, which has been, you are isolated. It contains some of the maternal genome and some of the fetal genome. You are sequencing everything. Parallelly, massively you are sequencing. There will be 10,000 or millions of DNA sequence will be there, which will be from 120 to 190 base pair. Smaller base pairs are more of a fetal, larger base pairs are more of a maternal. And you are sequencing everything. And you are getting small sequences of base pair sequences. Computer will align with the human genome project sequence data. And 21 sequence is there, it will keep in 21. 6th chromosome sequence is there, it will go and kept in 6th chromosome. Just like that, it will align entire sequences, and finally it will say that in a pool of that cell-free fetal DNA, how much percentage of trisomy 21 sequences are there. So generally we know our total human genome contain 1.3% of trisomy 21. So if mother is euploid and baby is euploid, it should be 1.3%. So that is true because that is statistics. When you are using 100 millions of base pair, every sample is there, large amount of sample is there, there will be 1.3%. If it is more than that, for a calculation I have calculated, at a 10% of fraction, it will be 1.365. So that is also in only very marginal increase is there. So if it is 2% fetal fraction, it will be very minimal. That is why when fetal fraction is very, very less, error rate is more. Understood? So this is the whole genome sequencing they are detecting. Whereas other targeted methods are there, like focus on the more relevant chromosomes like 21, 18, 13, etc. Only that can be tested. This can be done by targeted genome sequencing or the other method, SNP based method. But SNP based method having some limitation. For example, not useful for IVF with ovum donation. Because in SNP based method, we are looking at the single nucleotide polymorphism. The single nucleotide polymorphism are some nucleotide changes which is specific to one person. Same concept, you know, all of you know, you are using for DNA fingerprinting or paternity testing, etc. So where the same sequence should be there in the mother also. So mother maternal allele we will take, father fetal maternal allele we will take. What is the difference? How many? So compared to mother's maternal allele, if trisomy 21 alleles are 3 times, that means you are having trisomy 21. But here two problems will come. If it is an IVF pregnancy with ovum donor, SNP methods cannot be used. This is the importance of understanding is. You are sending to a lab where SNP methods are using and you are doing an IVF with a maternal or donor ovum, SNP methods cannot detect or false positive results can also come. Similarly, transplant, that is a very rare issue, a transplant. So these are the importance of understanding the techniques. Different techniques, each method has certain advantages and limitations. Its clinical implication, an interpreter should know. Otherwise, how will you interpret it? Just like X-ray and other things, we want to know these techniques also, then only we can correctly interpret. Coming to screening performance of NIPT, because conventional performance I told you, it is around 95% is the best method with a false positive rate of 5%. Here you see trisomy 21, 99.7% of detection rate. Against the best method of prenatal screening, which is 95%. That's the best. Usually if you do triple test only, quadruple test only, or one day, 70% detection rate. It will come around that. With the false positive rate of 0.04%. In multiple gestations, it will little bit low because multiple gestations, cell-free fetal DNA will be less. So there will be 98.2, etc. Trisomy 18 is a little bit low, 97.9. Trisomy 13 is 99. And sex chromosomal abnormalities, it is around 90% only. So it is not better to use. It's not recommended for sex chromosomal abnormalities because detection rate and false positive rate is high. If you come to the positive predictive value in not in this test, that is a basic statistics, basic epidemiology. Positive predictive values always depends upon what is the prevalence of the disease in our population. So if you use some screening test for dengue, if dengue is very common in our population, PPV will be high. If we are doing some screening test for Leishmania donovani, our PPV will be very, very, very low. That's a basic principle of any PPV. That's a basic concept. So here, when age is advanced, basic risk is high, a priori risk is high. So the risk is positive predictive value up to 99%, 91 to 99%. Whereas in a 20 years, positive predictive value is only 38 to 80%, that varies. Trisomy 18, some figure I have given, trisomy 13, because trisomy 13 is extremely rare condition. 18 is extremely rare condition. 21 is high. So generally speaking, for trisomy 21, in a little bit older age group, NIPS is a reasonable good test. That is the message I want to give you. Okay. So this is again same slide in a different model. That means so here you can see that trisomy 21 combined screening general population is 5 positive predictive value with a negative predictive value 99.8. Here it is 15% and more than 99%. So negative predictive value is a more than 99.9%. So to say a negative is a reasonably high risk. High value is there. Whereas positive predictive value, here it is only 5, it is 1 in 20. That means you have to do the 20 amniocentesis to identify one. So amniocentesis indications and procedure rate will significantly come down if you are using the NIPT. So what are the major causes of false positive rate? Low fetal fraction, maternal chromosome aberrations, confined placental mosaicism, maternal mosaicism, pathogenic copy number, vanishing twin. Because vanishing twin, as already we have discussed in last One of the twin is placenta is there. So if it is a dichorionic and different genetic proposition, false positive rates are possible. Placental mosaicism, there is a possible. Maternal cancer and other neoplasm and some reports including fibroid can produce a false positive or negative results. Recent blood transfusion and transplant recipients. Then some technical issues like 5 ml blood only you are sending, some problems are there. So there are so many causes of FPR and FNR. So compared to a traditional screening method, you can see that NPS anytime during gestation, more than 10 weeks you can do. It's a one-time laboratory test, no ultrasound required, no NTD screening, sex chromosome screening unless declined, not FDA approved, no call about 1%, inconsistent insurance coverage. But here one risk is there is 1 to 3% of failure rate is there. Whereas in first trimester, our conventional screening, there is no failure. But there are some failure. That means test will give you no results, no call, nothing, you got it. So there are some advantages, some disadvantages. But generally, NIP is having a better detection rate than this. But there are so many limitations, like cost, more than other screening methods, and almost same as invasive testing. So as a geneticist, I also felt invasive testing is a reasonably safe procedure now, amniocentesis. So why can't you directly, rather than doing a prenatal screening, if it comes positive, again you have to do the invasive testing, double cost. Double cost. So in a reasonably risk patient, why should you go for an IPS? Directly you can do amniocentesis. But that is why in some of the recommendations says, in a precious pregnancy, definitely NIPS is a better option. For example, bad obstetric history, advanced, they became pregnant, first pregnancy at 37 years, they don't want to take a abortion risk of even 0.5% or, because even the amniocentesis, we will give a risk figure of 0.5%, we will take a counseling. We know that now standard figure is around 1,000, 1 in 1,500, 1,600. It's extremely low procedure-related abortion risk for amniocentesis. CVS and little bit increase is there, but amniocentesis is a comparatively safe procedure. But there is a risk. For a counseling sake, there is a risk. So NIPS is a non-invasive testing. So all these things you have to discuss with them. Then time to wait for the results, availability of expertise, laboratory, etc. These are the certain limitations. And another major limitation is you will give you will have a subdue importance of ultrasound. Because in other combined screening, always you will do ultrasound. You will do nickel fold, you will do anencephaly, you will look for neural tube defect. All these things you will identify. Once this NIPT will come, it will available everywhere. What will happen? Obstetrician will send to NIPT and ultrasound importance will come down. So there is a possibility of missing of ultrasonological related markers in the early pregnancy. We will do ultrasound only in 16 to 18 weeks. So even if you are doing an IPT, a important nuchal fold thickness, nasal bone and early trimester scan is mandatory in your practice. But so importance may come down. That has been shown by some of the studies. And after the introduction of NIPT, number of invasive procedures are coming down. And another problem is universal screening if it comes. Then this choice for the pregnant ladies is very difficult. If you just imagine a situation, government has, just like immunization, government has brought with the situation that we have to prevent all Down syndrome children. So we will start this. Then whether it is ethically correct. Because Down syndrome is a condition where they can live. They can have so many plus points. So all Down syndrome we will identify and we will terminate. Ethically, is it correct? So if it is a universal screening process, we will identify a Down syndrome baby. But if it is a universal process, ethically, is it correct? There are so many in Sweden, Netherlands, so many issues came. They came with the universal program. So there are some ethical issues. So these are the issues which we are going to face when it comes to permanently. What about the patient perspective? Patient perspective, they are having a happy because better accuracy, less physical risk than diagnostic testing, earlier availability of the results, especially in first trimester. But concerns are too widely available. That I told you, just like the consumer testing, anybody can go and take blood and give a risk. Then even obstetrician will not write. They will come with the NIPT result to you. Just like pregnancy test, nobody is writing now. Now they will come with only because yesterday was telling when answer they have written, pregnancy test, go to the medical shop. because one answer somebody has written like that. Because nowadays students are learning like that. In recent DNB exam, when I have seen a question, arrhythmia, management of arrhythmia, refer to pediatric cardiology. Because that is the only thing pediatricians are doing. They are treating cardiac failure, but they are not treating arrhythmia. Now there are so many pediatric cardiologists. So arrhythmia naturally treated by pediatric cardiologist only. So undergraduate will refer to pediatric cardiologist. So similarly, NIPT, they will come with the results. You don't have to write. So then it will be a problem because there is no counseling. What is NIPT? Or letting there's no. Then simplicity may undermine informal decisions making, inequality to cost and access, pressure to have test, terminate pregnancy affected, insufficient pre-test information because counseling we are not giving. So in a clinical practice, ACOG clearly states that physicians should be aware of the potential of NIPT to generate a false positive, false negative results, and it is not equivalent to diagnostic test. That is the first important message I want to give. And all NIPT tests should be combined with a pre-test counseling and post-test counseling. So in implementation, there are two types of implementation, option 1 and option 2. Option 1 is NIPT to everyone at 10 weeks. As a gynecologist, you are practicing in a center where everybody can afford. Every 10 weeks you can do it, but then you make sure that first trimester ultrasound and combined test, if you want, you can do it, or first trimester ultrasound you can do. Any pregnancy with a high risk score, invasive testing can be done. Advantages, it's a universal, means in your population. We cannot say it's a community universal. Whatever patient comes, 10 weeks, booked case, you are doing it. Decision in the first trimester can be taken. Option 2 is contingent test, that is first trimester you will do, at 16 weeks or something you will do it depending upon the positivity. So there are two advantages and disadvantages for both options. Always pre-test counseling should be done. Screening is optional. Clinical features of trisomy 21, etc. has to be described. Difference between screening test and diagnostic test should be explained. These are the points should be discussed during pre-test counseling. Various options of prenatal screening and their comparison, because you should not everybody expensive test has to be done. And what is the technology, test performance, PPV, NPV, accidental findings, sometimes you may detect, cost, turnaround time, follow-up test. Everything should be explicitly told in the pre-test counseling. And when you are, this is one test, always look for fetal fraction. If fetal fraction is less than 4%, they will also not give the result. It is unacceptable. 10% is best acceptable. Most of the time in 12 weeks, 13 weeks, you will do around the 8%, 9% will be the routine value. Here it can see that it is high risk for trisomy 21. They will give only high risk or low risk only. It is not positive or negative, or it is not affected or not affected. It is high risk, then followed by testing. And post-test counseling, you have to do screen positive, screen negative, and test failure. Screen positive, you can do two things. If they are willing, you can directly go to diagnostic testing. If you have to counsel them, or detailed look ultrasound, and based on that you can decide. That depends upon the, if you have any doubts are there, you can refer to an expert also. Screen negative, you can tell that invasive testing is not recommended as per the test. But at the same time, please counsel that we are looked only for these 4 or 5 aneuploidies. Other genetic testing, other genetic disorders, other chromosomal abnormality, because they will feel that we have done a test of 10,000 or 15,000 worth, where genetic cfDNA has been done, and baby is 100% perfection, no genetic abnormality, ISO certified baby. That cannot be guaranteed, that has to be counseled, and it has to be combined with ultrasound and other thing. Test failure, there are a lot of things has to be discussed in test failure, but test failure generally means, one thing is I told you, aneuploidies will be missed. So there are two options are there. Repeat testing is a possibility, but in a repeat testing, around 50%, again you can get, but time will be delayed. So generally, most of the people would recommend or something in test failure, better to do an invasive testing, because aneuploid is a high chance. Or do a detailed ultrasound, because that is an area which is a little bit not definite recommendation. I don't want to tell that. So now recommendation I am not going because time is not there. I will say a lot of recommendations. ACOG, your own organization, our organization, American College of Medical Genetics, then IUCOG, RCOG, ISPAT, our IAMGs, we are going to come up with an NIPT guidelines within 1 year. We are writing now that. So there are so many guidelines are there, but everywhere, everything I have told, importance of prenatal genetic screening. That first you have to tell. It is, every pregnant lady has to be discussed with that, and multiple screening tests should not be done. Because same time NIPT with the combined test, with the quadruple test, with the triple test, because there is a conflicting results. These are all screening tests. It is not a definitive test. So multiple test, screening test should not be done. Stick on to one screening test. Then NIPS, at present cell-free DNA is not equivalent to diagnostic test, but it is a highly specific and sensitive test. Post-test counseling, already I told you. Test failure, already I have discussed. Then importance of ultrasonography, already I told. All patients should be offered, and if there is a clinical situation of soft markers, then look for aneuploidy screening. If it is positive, then I think these are all NIPC as a follow-up test. Can be done in a precious pregnancy or in some rare situation. Multificial gestation, already we have discussed. Inaccurate results or multiple aneuploidy is another problem. In monogenic disorders, now it is not routinely recommended. Only RH status, negative women status can be tested. And in outside India, X-linked disorders, sexing can be done and decide on that other test. But it is not approved or not recommended in India, so we cannot do that. Rest of the monogenic disorders, at present, it is not there. But there are so many studies or protocols are there where new autosomal dominant disorders like achondroplasia, Apert syndrome, Noonan syndrome, 100 disorders, we can do NIPT. We can do sporadic autosomal dominant disorders, but we cannot do testing for if mother is X-linked or father is having some disorders, cannot be tested in the cell-free fetal DNA. So there are so many limitations, so many positivity. This area is fascinating, may come next few years, so many things can come. Then the cell-free fetal DNA can also be used for preeclampsia, preterm birth, infection during pregnancy, maternal cancer detection, etc. So many protocols are under the research protocols, but it's not routinely applicable. Summary and conclusion, NIPC, NIPT is robust, reliable, advanced technique, which will be the future, no doubt about that. Clinicians should be aware of the limitation of the test also, and some of the things about the technicality, so then you can counsel them. It is not a diagnostic test, needs a confirmatory test as per the present recommendations. Pre-test and post-test counseling should be an integral part of any test. Without that, don't offer NIPT. Just with a prescription, go and do NIPT, and it's not recommended. And universal coverage with NIPC and NIPT is the goal in the future, which will definitely help you to read. Thank you very much for patient listening. Any doubt is there, I will answer.
Thank you, sir, for the enlightening keynote on the area that holds great promise for safer and smarter care. Now, Dr. Sridevi may please hand over the memento to Dr. Shankar as a token of our appreciation and love.